An alternative option to hemodialysis is peritoneal dialysis. Patients must have a peritoneal dialysis catheter placed into their abdominal cavity. The catheter is placed 1 month before starting peritoneal dialysis so the area can heal. The abdominal cavity is covered in small capillaries, and these capillaries act as filters. Through the peritoneal dialysis catheter, dialysis fluid is instilled into the abdomen. The fluid sits in the abdomen for several hours, allowing for chemistries to be balanced, toxins cleared, and fluid to be removed from the blood in the capillaries. This is based on the concentration gradients between the peritoneal fluid and the blood. Then the peritoneal fluid is drained from the abdomen and discarded. New fluid is instilled and the process starts over. There are 3 major layers of the peritoneal membrane: the mesothelial layer, the interstitial space, and the capillary endothelium. The mesothelial layer provides minor resistance to the flow of toxins. The major barrier to solute transport is the capillary endothelium. The capillary endothelial cells have 3 types of pores that allow movement of water and solutes. The aquaporins allow water across the cell membrane, and they are stimulated by the osmolality of the dialysate. The small pores transport small solutes such as urea, creatinine, and electrolytes. The large pores transport larger macromolecules, such as proteins. There is a higher density of aquaporins in small pores compared to large pores. Similar to hemodialysis, the movement of water and solutes occurs by 2 processes: diffusion and convection. Diffusion is the main mechanism of small solute transport in peritoneal dialysis. Diffusion is dependent on peritoneal membrane surface area, the solute concentration gradient between the blood and the dialysate, the dwell time of the dialysate in the peritoneal cavity, and the dialysate flow rate. Solutes are transported from the blood to the dialysate or the dialysate to the blood, depending on the concentration gradients. For example, there is no urea or creatinine in the dialysate, but there are high concentrations in the blood in end-stage renal disease, so urea and creatinine will move from the blood into the dialysate. The dextrose concentration in the dialysate is much higher than that of glucose in the blood, so that will move down its concentration gradient into the blood. Smaller molecules will diffuse faster than larger molecules. Diffusion of solutes in peritoneal dialysis can vary from patient to patient and is determined by the degree of vascularization and the amount of inflammation present in the peritoneal membrane. Remember, ultrafiltration is the movement of fluid across the peritoneal membrane in response to osmotic forces. Convection occurs as dextrose in the dialysate creates an osmotic force that causes water to move from the blood into the dialysate. With the water, dissolved small solutes move from the blood into the dialysate by solvent drag. Ultrafiltration uses both aquaporins and small pores. We can modify the amount of ultrafiltration that occurs by changing the dextrose concentration in the peritoneal dialysate. The higher the dextrose concentration, the greater the ultrafiltration. Over time, the dextrose in the dialysate will diffuse across the capillary membrane, and the osmotic gradient will dissipate. It's worth mentioning that there is also lymphatic absorption from the peritoneal cavity. The lymphatic transport rate is about 2 liters per day. It's usually negligible unless there is a problem with the lymphatic system. So the net fluid removal in peritoneal dialysis is the ultrafiltration osmotic forces minus lymphatic absorption. Peritoneal dialysis only takes place at home. Unlike home hemodialysis, patients don't need a partner to perform the dialysis. It's usually done daily. Peritoneal dialysis can be done 2 ways: through manual exchanges known as continuous ambulatory peritoneal dialysis, or overnight through a cycler known as automated peritoneal dialysis. There is no morbidity or mortality difference, and preference is based on the patient's lifestyle. Some patients are not candidates for peritoneal dialysis, such as those with abdominal cancers, those with ventriculoperitoneal shunts, and those who have had major abdominal surgeries, because scar tissue can limit peritoneal filtration. There are some benefits to peritoneal dialysis. The fluid removal is usually gentler than hemodialysis, which prevents intradialytic hypotension. The blood pressure tolerates the fluid removal because the dialysis is done daily, and fluid is removed at a slower rate. Also, due to daily dialysis sessions, the diet is less restrictive. There are some disadvantages to peritoneal dialysis. such as the need to have a home with space for all the equipment and supplies. Also, the dialysis solution typically contains a lot of dextrose, which can be an issue for diabetic patients, but this can be managed by adjusting insulin dosages.
So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free trial account which will give you access to selected chapters of the course. If you want to learn how MedMastery can help you become a great clinician, make sure to watch the About MedMastery video. So thanks for watching, and I hope to see you again soon.